Kia ora tātou, everybody. Bruce Arnold's my name, and I'm the head of the director of the Goodfellow Unit. It's my great pleasure tonight to introduce Dr. David Codyre, who is my favourite community psychiatrist. He's been working in primary care for over 20 years, first with ProCare and more recently with Tamaki Health. He's still part-time with Tamaki Health. He's involved with the Auckland Wellbeing Collaborative, which is supporting the hips. So for those of you who have the hips in your practice, David will be behind them providing support. And he's also involved with the National Telehealth Service 1737, if you have patients wanting to call that. So an extremely experienced psychiatrist, and he's going to talk about how to deal with crises in primary care. So David, welcome to the Goodfellow webinar. And
thanks, Bruce. Yeah, good to see you too. It's been a wee while, hasn't it? All right, well, welcome everyone and good evening. Bruce had asked me to just do a talk relating to crisis presentations in primary care. So I'm just going to, obviously this is a big area to cover. So I'm mainly going to focus on what I think the 4 primary or most common crisis presentations in primary care. And I've said to Bruce to interrupt me on the way through if there are questions related to what I'm talking about. So I'm happy to field those on the way through. So look, as I kind of see and understand it working in primary care with GPs and their teams, it seems the 4 main important areas are firstly, someone who's distressed facing a life challenge and trauma. So it may relate to their own life or in more recent times also to the events of the last years. I mean, the Christchurch terror attacks, before that the Christchurch earthquakes, the impact of COVID, and more recently the floods. And in fact, for many in our communities and indeed for ourselves, it's really been one thing after another, hasn't it? So we can all only cope with so much. But also past and especially developmental adversity also leaves people with poorly developed coping skills and more vulnerable to decompensate in the face of stresses or trauma. Secondly, though, is the distressed person who has severe enduring major depression with associated suicidality, so the crisis being around the severity and risk. Thirdly, though, and unfortunately, it seems increasingly common as community stress and distress levels increases, the numbers of people presenting as angry and threatening in practices, and also sometimes also persistently self-harming and suicidal. And then lastly is the much less common scenario of a person who is experiencing psychotic symptoms which are causing behavioural disturbance and presenting in primary care. So the first and last, the first is common but less challenging. The last is very uncommon, but up to a point more straightforward. So I'm just going to very briefly touch on them and then spend most of my time focusing on the severe depression with associated suicidality situation, and also the more general issue of people who present angry, threatening, and or with persistent self-harming and suicidal thinking. So, I mean, before we dive into that, though, there are some just general messages about people presenting acutely distressed and in crisis. And with the behavioural disturbance that sometimes goes with that. Hopefully I'm telling you nothing that you haven't already got in place, but it does sometimes surprise me to find that practices don't have a clear clinic protocol agreed by everyone for distress presenting at the front desk. So I really suggest that practices have a clear protocol visible to reception staff, so, you know, in their workspace, and ideally also ensuring all staff have access to de-escalation training. One of the things that really impresses me about practice reception staff is that many of them actually intuitively manage distress well and de-escalate well, but don't have confidence that they're able to do that. On the other hand, there are staff who just don't have those skills intuitively and who either really struggle themselves or respond in ways that actually escalate distress rather than de-escalating. And really, I mean, that should just be a simple protocol about reminding people first to take a breath and calm themselves, and then try and respond as calmly as they can with empathy. To try and find a quiet space in the clinic that you can direct the person to, both for their own peace of mind, but also to reduce disturbing other patients in the clinic, offer a cup of tea and so on. Often that's very, very kind of de-escalating for people if in concern ensuring a staff member stays with them or in the immediate vicinity. Ideally triage as soon as possible. If you have a hip health improvement practitioner in your clinic, they may be able to respond very quickly, either if they don't have someone with them at the time immediately, or certainly as soon as they've finished with the person they're with. But on the other hand, the reality is that sometimes, sadly, people are abusive and threatening, unable to be calmed. And, you know, sometimes we do just have to ask people to leave, and if they will not, involve the police. I mean, above all, we have to keep ourselves, other patients and our team safe. And the other thing is, you know, I think it's really important to have a clear panic button process in place so that if someone does find themselves unsafe, there's a process for raising alert. And in terms of us as practitioners, it is very similar. It's just take that 2 seconds to breathe and ground yourself. Reflect in a calm manner using neutral language. I can see things are easy, not easy right now. Try to get the person's attention and invite them to do some slow, deep breathing with you. So the simplest method of that is so-called box breathing, which is basically getting people to slowly breathe in for 4 seconds, to hold for 4, exhale for 4, and hold for 4. And if you can just count people through that cycle of 4-second in, hold, out, hold, that really elicits the autonomic calming response, which is so powerful. And I mean, I in my practice, not uncommonly see people who are actually beyond distress and an overt panic. And sometimes you need to be quite direct of doing this, but it just never ceases to amaze me what a powerful tool it is. Bruce and I were talking actually earlier about a different approach he has, which is very much around also putting, maybe you should talk to that, Bruce, but actively putting your hands on the person's chest to get them doing that slow breathing.
Yeah, okay. Well, I learned this from Rex Hunton, who was one of our teachers when we were medical students. David and I were at Auckland, and he used to teach us saying it works for patients who've got an acute asthma attack because often they're hyperventilating. But I've actually used it once in a woman who did have asthma, but she was actually having a panic attack. And I stand beside them. You have to ask their permission, of course, and you put your hand on their chest and you push. It's not CPR, but it is just pushing. You take control of their respiratory rate because they'll invariably be over breathing. Yeah. And those of you who saw the polyvagus will know that when you start breathing slowly, your heart rate slows and your heart rate variability improves. And I've only ever had to admit one asthmatic to hospital since I learned this about 30 years ago. So it's a very good way because it does a whole lot of things. You put your hand on the patients, which is comforting, I think, because they're
therapeutic in itself. Yeah,
very therapeutic in itself. And then you just slow their heart rate and they come back into the room fairly quickly. And if they breathe slowly, the heart rate cannot help but slow down. It's just built into all of us. It's saying in our minds, it's all safe, it's all clear. So there's no dangerous animals out there because we start hyperventilating when there's dangerous animals around. Yeah, so it's a good little trick. So it's gentle CPR with permission.
And look, I mean, I don't think you can really underestimate the power of simply taking control of breathing and the breath. I mean, it does have this cascade of effects, both immediate and longer term. And certainly the breathing associated with mindfulness in a very similar way in terms of learning and practicing that. I mean, the other thing
I teach the box breathing actually is to say the Navy SEALs do it, and the patients really like that.
Oh, yeah, okay. Well, that's a great idea.
Nice little selling point, yeah.
So look, the other thing that can be really helpful in the moment is just basic grounding. It's kind of distraction and also, again, bringing people out of their mind where they might be having catastrophic or other thoughts into their more physical self. So just to direct their attention to the feel of the floor under their feet and also the feel of the seat they're sitting on, the back they're leaning against, and sometimes also then focusing on noticing sounds they can hear and so on, but just that basic grounding people in the moment. And doing that, typically people's distress will reduce, and then once distress reduces, you can then start the job of assessing what's going on and how to make sense of it. So moving on then to that first scenario, the person facing a life challenge or trauma that's tipped them into a state of being overwhelmed. And that may be accompanied by acute low mood, depressive symptoms, and indeed suicidal thoughts. And I mean, historically, we were all taught that depression, if it's been present for 2 weeks, you need to treat. But actually, I think that the thinking about that has changed. And I mean, as Bruce said, and I commonly repeat to GP colleagues, most people presenting in primary care with severe depression are seeing you on the worst day of their life. So they may have been struggling for a time, but things can change very quickly. So if their people are usually well, then with normalizing distress in the face of acute life stressors or traumas, reassurance that they will recover, that this will pass, then and also particularly giving people some simple advice and tools, which I'll go on to talk about, then most people will actually recover relatively quickly without necessarily needing more biomedical treatments for depression. Provision of ongoing GP team support, empathy, and reassurance about recovery is enormously therapeutic in itself, and certainly phone follow-up by a team member adds even more value. That team member may be a practice nurse, a health improvement practitioner, a health coach, or yourself. However, it's still important in this context to assess for risk and to manage that as you usually would. And I'm going to go on and talk more about some of the recent advances in understanding, assessing and managing risk later on in this talk. The fourth really key thing is encouraging people to keep to normal routines and use usual healthy coping mechanisms. I mean, when people are distressed and out of sorts, they tend to abandon the things they normally do to maintain their well-being. So really encouraging keeping up with exercise, keeping sleep routines, and if necessary, getting people to practice the basic steps of sleep hygiene, maintaining leisure activities, reaching out for social support. All of those things are incredibly protective, particularly when we most need them at times of stress and distress. Corollary to that is discouraging unhealthy coping mechanisms, especially the recourse to the use of alcohol and drugs as a way of coping. If your practice has a HIP, then this is a great opportunity to warm hand off for further support, to coach them in skills to manage and to agree a behaviour change plan. And when the mantra of HIPs really is skills before pills, and I think that having a HIP colleague is a great opportunity to really focus on prescribing when it's going to make a difference. And first of all, teaching people skills. And then 7, obviously, lastly, it's important to alert the person that if symptoms worsen and or particularly if keeping to usual function is a struggle, so people are just not managing with normal occupational, family and social function, then it's critical to reach out for help early. So that's the basic approach to the life challenge trauma situation. The second one I'm going to go to is the person with psychotic symptoms causing distress. And again, this is rare. The what to do is much more straightforward. So I'm just going to cover it fairly briefly. But acute psychosis presenting as distress is rare, but also really important to actually be clear about and know how to respond to. The same general principles of reducing distress apply, but may be really much more challenging to apply effectively in this case. When psychotic symptoms cause distress, they will usually be pretty obvious. So people will present either with behavioural change in terms of very disorganised behaviour and or behaving in a very paranoid, suspicious way, or in illogical and or unusual content of speech. So it's people whose speech is hard to understand, it's hard to make sense of what they're saying, or that they're talking about things that to you are not based in reality. And I mean, I don't think it's reasonable to expect GPs to do an in-depth assessment of psychosis, but just to be able to recognise it and respond to it. So any person distressed with symptoms of psychosis really requires semi-urgent or urgent secondary mental health service referral. And certainly mental health triage nurses, though, require accurate information to make the correct triage decisions. I'm involved across the primary secondary space, and so have been involved from time to time in adverse event reviews between primary and secondary services when things go wrong at that interface. And one of the things that really commonly comes up is that a GP has attempted to kind of document what's concerning them, But triage nurses at the other end of that referral process are not kind of seeing the things that are going to ring their bells around understanding the severity of the presentation. So particular things that's really helpful to assess and document very explicitly is, firstly, if there are hallucinations and particular command voices, and even more so if they involve harm to others. So just screening for voices, asking if they involve command, and if those commands relate to harm to self or others is key. Secondly, it's being really explicit about the presence of delusions, unusual beliefs, but in particular, again, if they involve the person feeling at risk from others, and even more so that those others being known to the person, because in that situation, people who are normally not prone to any kind of violence can act to harm others in the belief that they're protecting themselves. Those are more straightforward, but the two other things that are sometimes really difficult to make clear in referrals is the level to which very disorganized and or agitated behavior is putting the person at risk. So someone who's very agitated and disorganized, part of that is being very unaware of your surroundings and can result in people walking under the road and doing other things that put them at risk. So really clearly documenting that. And also, obviously, any psychotic symptoms along with thoughts about harm to self or others is really critical. I haven't put it here, but obviously, if necessary, this is a situation in which implementing the compulsory assessment elements of the Mental Health Act is really critical. One thing that initiating that Section 8A, 8B process does is mean that a psychiatric assessment has to happen. So that's one way to ensure that someone you're really concerned about does actually get to see a psychiatrist. The other thing is, this is the one situation in which sometimes medication can be required acutely to reduce severe distress and any associated risk. And generally what would be recommended will be oral lorazepam 2 to 4 milligrams for an adult, or if it's really much more acute disturbance, olanzapine wafers 5 to 10 milligrams. The olanzapine wafer is just being absorbed more quickly. Key thing is you cannot give people both together. So look, moving on to one of the areas I just wanted to spend a bit more time with. So it's a situation of someone where depression is enduring, more severe, and as a result of that will be impacting function, and so a more thorough assessment of mood and risk is required. And again, for those of you that have or are soon going to have the integrated model implemented in your clinics, if you're time pressured and have a HIP in the clinic, hand off to them can be really helpful to get that more in-depth assessment. But what I really want to focus on is the evidence and practice about assessing and managing risk, which have shifted in recent years in two dimensions. The first is the recognition that we cannot actually predict risk, that actually suicidal ideation is a not uncommon phenomenon. Suicide attempts are thankfully rare, and completed suicide even rarer. So to have a predictive test that actually differentiates the 1 in 10,000 who is going to end their life from the thousands who are not requires impossible sensitivity specificity. So we all need to stop believing we can make decisions about care based on risk assessment. So there's been a real shift from that to more understanding how to accurately assess real risk intent and to have a process around safety planning. The other thing to just comment and highlight, though, is that there's been a real recognition that for mild to moderate depression, antidepressants are seldom effective, and certainly generally the harms outweigh the benefits. But severe enduring is where there is clear evidence of antidepressant medication being indicated and effective, and that's where really the assertively treating and actively follow up using recall systems and including phone follow-up is really key in terms of GP role. If functional impact is severe, distress, agitation is severe, and or there's significant risk, though, that is where semi-urgent or urgent mental health service referral again should be made. And again, picking up that same factor about how to communicate the things that are going to actually raise the flags for triage nurses. The important factors to stress are firstly around suicide risk. Is there an active plan? Is there intent? Is there access to means? is their belief would be that others would be better off if they were dead. And also, is there a lack of protective factors? Because all of those things cumulatively stack up actual risk. The second thing is to really, though, be clear about the markers of severity that are concerning you, because the challenge is, even though general practice has changed from that kind of continuity that was there 10 or more years ago, I think still people in general practice teams tend to know their patient population. So you will see the deterioration, but unless you make it really explicit for a triage nurse who's never met this person, it's hard for them to actually appreciate that. So first, around markers of severity is really that really documented extent of deterioration in function and in self-care from baseline. The second thing is stressing the biological markers of severity. So things like psychomotor agitation or retardation. So the person who's pacing the room, wringing their hands, distraught, and or is kind of psychomotor retarded. So is sitting virtually motionless in the chair, downcast, often with increased latency of response. So that delay between you asking a question and getting a response, and it often being a very minimal response. Weight loss is a really important marker of severity. And also severe rumination with themes of guilt, of past perceived misdeeds, and so on, that are really key to really clearly document. And again, I mean, if you're increasingly or sufficiently concerned, I think it is also important to consider initiating compulsory assessment, as I said, in terms of the psychosis situation. What I'm going to do now, though, is go on and talk a little bit about the shift from the notion of risk assessment to that of risk formulation. And this is a response to the recognition that we cannot predict who is at risk and who is not, and therefore should not be making decisions about level of care based purely on that. So the first bit of this, and the bit that actually when this literature first started to come out, that I really resonated with, was how to get beyond stated intent. And the reason for me that kind of seemed to make so much sense is that in my 30 years working in mental health, I've had 3 people who I've been working with die by suicide. None of them were the people that I was actually worried about at the time. That's a shared experience that many other people have talked about. And I think it's because people's stated intent, if they're really at risk, and often beyond that as well, is actually seldom reflective of their real intent. And indeed, sometimes people who are most at risk are most minimizing their intent because they don't want it known. So there's this whole so-called case approach developed by an American psychologist, Christopher Shea, which I'm going to go on and talk a little bit about in terms of getting understated intent. So the first thing, and this is probably much more kind of makes sense, has face validity for people, and many people do this anyway, is just around the 2 ways of sensitively uncovering and addressing the topic of suicide. So the first is asking the initial question in ways that normalize it. And certainly this is predominantly what I've tended to do historically. So to kind of say something along the lines of, it's really common when people are feeling a lot of emotional pain that they think about suicide. Do you have thoughts of suicide? So kind of normalizing it for their context. Or sometimes when people are in tremendous amount of pain, they find themselves having thoughts of killing themselves. The next thing, though, is also the kind of shame that can go along with these thoughts and how to attenuate that through kind of linking it to experiences. You've been experiencing so much pain recently. Have you been having thoughts of killing yourself? With everything you've been going through, have you been having any thoughts of killing yourself? Or with all your pain, just find your own way of saying this in a way that also kind of almost makes it normal, but also reduces the sense of shame that might go with feeling that way. The more important thing, though, that I've found really helpful is these so-called 5 validity techniques used to explore the actual extent of suicidal ideation. So the first is really deconstructing in detail the actual behavioral incident, if there has been a suicide attempt, or indeed a person preparing or getting to the point of acting. So asking very explicit things such as, how many pills did you take, or how many pills did you hoard with the intent to take? you know, if the person has talked about cutting their wrist, did you actually put the razor blade up to your wrist? How many pills bottles did you actually store? What did you do right after you took them? So really just getting down to detail. The second thing is that whole, what they call gentle assumption. So how often are you thinking about suicide? If the person's drinking in relation to their being at risk, how much did you drink? What other ways have you thought of trying to end your life? And then symptom amplification. And I mean, to me, this makes a lot of sense because it's what I and often people are taught to do in terms of substance abuse. If you overstate what it might be, the person is much more likely to bring you back to what they honestly are doing than if you just ask the question in an open-ended way. So, you know, I mean, you know, in terms of the explicit, if the person has thought is about hanging themselves, how often do you think about it? 80 to 90% of the day. On your very worst days, how much time do you spend thinking about killing yourself? 70% of your waking hours, 80%. Then there's also the kind of denial of the specific. So do you think about hanging yourself? So being very, very explicit. Have you thought about jumping from a building? So going beyond what people state in terms of potential means to actually asking about other means. And then lastly, just a catch-all, just to say, you know, are there other ways you've thought about we haven't talked about yet? Now, this may feel very uncomfortable to do, and it may also worry people about putting the idea in other people's minds. But actually, you will never put the thought in someone's mind if it's not there, firstly. But secondly, if the thought is there, it's really, really important that we know about it to get under their stated intent, to understand their real intent. So that's one element then of what then can contribute to a risk formulation, and a risk formulation being a step beyond thinking about assessing risk to more understanding it in a context. So it's the bringing together of clinical data, the kinds of things that we're trained to talk about, you know, strengths, protective factors. Are there long-term risk factors, things like social isolation, you know, chronic medical condition, recent bereavement, past attempt, and so on? People who have a history of impulsivity and self-control issues, including particularly when if they're using substances. Past suicidal behavior, as I've said, being a strongly predictive factor. But then their current state, so their recent and present suicidal ideation behavior as much more implicitly uncovered by that prior set of steps. Current stressors and precipitants, their degree of symptoms and suffering from a more psychiatric perspective, and also the degree to which there's an engagement and alliance or not with the person, which is that kind of gut feeling or connection or not. And those things together can bring you to assessing both the current risk state relative to others in a population of people at risk, their risk status, but also their risk state, which is themselves relative to their baseline. Which, along with then understanding what their strengths and social supports are, can give us a sense then of what their likelihood of foreseeable change is. Because the thing is that suicidal risk is dynamic, and you see someone maybe at a time of heightened distress, you can de-escalate that with them, you can agree a safety plan, which I'm going to go on and talk about, but actually their risk can fluctuate with time. So we need to be aware of all the factors that may actually contribute to that. So I'm covering a lot of ground in a short time, and there is there is training available to sit behind this. A number of the regions that have been implementing the integrated model with HIPs and health coaches and NGO support are actually in the process of looking at training up the HIPs and their GP colleagues and using this much more comprehensive approach to formulating risk and also getting to true intent. So all of that then leaves on to safety planning. Now, obviously, if someone's level of risk is such that, and particularly the likely fluctuation in vulnerability is going to be significant, then they're the people who you really want to get connected into secondary services to get that level of care. But if the supports around the person are good, that the level of severity of real intent is not high, and there's not a lot to suggest that risk will fluctuate dramatically over time, then the last bit of this is actually a much more intentional process of safety planning that has historically been the practice. And it's a recognition that problem-solving capacity diminishes during times of crisis. And so having a specific template and steps to take can enhance coping. And when this process is used cumulatively, it's shown in research to contribute to an up to 40% reduction in suicidal behaviours compared to treatment as usual. So again, obviously that there are time implications of this. If you have a HIP, then certainly when they're trained up to do it, that will be a major part of their role. But there's a 9-step safety planning process, which is identifying what are the warning signs, what are the issues or stresses that cause me to feel suicidal, things I can do to actually begin to resolve that, but also what are my warning signs that I'm getting into distress. What are my reasons to live? So having people really explicitly articulating their protective factors. Things the person can do by themselves, which is often about distracting them and or doing things they know calm them. The social situations and people that can help to distract them. People who can support them and that they can ask for involvement in this plan. And then most importantly, making my environment safe. So going back to that earlier, getting into real intent, getting into all the ways in which people have had thoughts or a plan about how to act on it. It's about reducing access to means. So involving a third party to get the pills out of the house, to get the rope that's in the garage out of the garage and out of their environment and so on. And then lastly, professional supports, the contact numbers for you, your practice, HIP if you have one, and the local crisis team. So I've alluded to this a bit, but the whole piece about access to lethal means is on its own one of the few suicide prevention strategies that's proved to be effective. It needs to be a collaborative process though, because the reality is if you remove lethal means, then people are much less likely, if they do go on to act, to make a lethal attempt. So it's about identifying the method through that, getting understated intent to real intent, locate what the location of that means is and actions to mitigate it, and being really clear about roles and responsibilities in that, and if necessary, involving a family member in that plan. And then we have a great local resource in New Zealand to then structure that whole safety planning process. So it's an app called Manawa, which is downloadable from the App Store, but there's also a whole lot of resources on the Mental Health Foundation website using this link. And you can literally get a person to download it on their device, quickly go through and complete the plan with them, and then they take that away with them. And as I said, there is really good evidence that if you do this in the situation where someone's at not such immediate acute risk that need a crisis team referral, that you can actually then give them a really robust plan so that they can go away knowing what to do if they do find themselves at risk. So look, Bruce, that's the end of that bit. And because there's a lot in that, I just wondered if maybe we should pause to take some questions before going on to the fourth one, which is the distressed, angry, threatening person.
We're talking about that technique I use. When someone gets angry, do you ask them to try breathing or grounding techniques? And I thought, well, that's probably not a situation you want to put your hands on a patient.
No.
They're panicking if they're clearly tied up with themselves. That's okay. Anger, I think, is a different. Do you want to?
Yeah. Indeed. I mean, I think that if someone's really angry, the first thing to do, next to calming yourself, as I said, is just to really reflect using neutral language. So, I can see that things are really tough right now. What can I do to help? Display empathy. And what they will tend to do in most situations is reduce that, particularly if people underlying that is that actually they're severely depressed or situations of that. I mean, what I'm going to go on and talk about is the angry, threatening person in the absence of a significant mental health condition. but certainly you don't want to put your hands on a person who's angry, but certainly once you can get them engaged a little bit through that kind of gentle reflection, showing empathy, is then if people are angry, that same box breathing and grounding, just as it takes you out of severe anxiety, will also de-escalate anger. So I certainly think that that can be a useful thing to do. If the thing is, you've got to really, though, get the person's agreement to do it. So I like your idea of the Navy SEALs using it, but just anything to kind of say, look, people often find when they're feeling heightened emotion, it's really helpful to just do some simple breathing exercises. Will you do that with me? And I think the really helpful thing is also to have a sense of doing it with rather than to as well for someone who's in a heightened state of distress, particularly if angry.
In the polyvagal model, it's called the vagal brake. So if you want to put the brake on quickly,
yeah,
brake slowly. It's
absolutely. It's pretty straightforward. I mean, in an ideal world and over time, I think we will have access to training and all of these steps I've taken everyone through. But I mean, even before I was trained in this, I found it a really useful tool to use, and people can then take it away, and it's a resource for them to help kind of preserve their safety. There are a number of places that training can be accessed using these kind of steps that I've taken you through very quickly. I mean, I guess my aim today was just to really make people aware that there has been a shift in practice, and to look out for training as well as just to apply it. You can apply this stuff in your own practice really without too much difficulty, although ideally accessing the training I think is really, really helpful.
I did like your comment about having a safety protocol for the front desk, because I'm sure most of our colleagues know the front desk get a lot of trauma from patients, sometimes angry patients and things. It's quite a tough job in that sense. So,
oh look, it isn't, and particularly anecdotally, what I hear is that it's become more and more common as there's just been more and more to deal with over the last 3 to 4 years and beyond, really, unfortunately. You know, the thing that strikes me particularly about front desk reception staff and also nurses is that they have a lot of skills, but low confidence in the skills they have. And so, you know, I've seen, you know, front desk staff and practices manage, you know, a really agitated or angry person really, really well. But often when you talk to them, they feel shaken up because they don't feel they have the skills to manage it. So particularly having the de-escalation training, have a really clear protocol can just help to kind of compensate for that. But actually also there are those who actually just really struggle with it. And I think that for them, along with that, access to de-escalation training is really, really important.
A few questions here. A nice one here from Victoria. We have a weighted blanket in the hips room for people experiencing anxiety.
Yes.
Do you think offering blah, 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 blah may be suitable as part of a routine resource crisis? So
yes, so look, again, for people who are distressed, and particularly in the context of sometimes anger, but also heightened distress and of other kinds, that there's quite a strong evidence base for the use of weighted blankets and other kind of, what's the word? I was going to say sensory deprivation. Sorry, I have a mental blank. But it's just ways, it's ways of actually giving people a sense of safety and comfort, and certainly weighted blankets is one very good way to do that.
Great, so that's fantastic. Do you know when the training for HIPS with regard to risk formulation will be rolled out?
So Southern, it's in process. Auckland, it is coming. So as a first step, because counties in Manukau district are training all their secondary mental health staff in use of this so-called safe side process. We have a number of each of the PHOs has a number of their key HIP leaders attending that training. And already the very clear message has come back, yes, this really can be integrated into our HIP practice. So there's a bit of an evolving consensus that we want to get everyone trained in using this approach. I'm not sure where things sit in terms of the Midland and Wellington and area. But I mean, this approach is developing such a strong evidence base that I think it will gradually spread and become the normal.
Somebody, Annie suggested sensory modulation was the word.
Sorry, that's it. That's it. Sensory deprivation, sensory modulation.
You've been in the game too long. How do we manage this in 15-minute consults? Any helpful tips?
Yeah, look, I think it is very much about cutting to the chase, isn't it? And particularly if risk is there, you've just got to focus on that. I look, realistically, I don't think you can do it in 15 minutes. Some practices will have more access to extended consult funding than others. Certainly, where people are eligible for it, that can help. But just as, I mean, if someone presents in a clinic with symptoms of potential myocardial infarction or other severe acute illness, you can't do that in 15 minutes, really, can you? I mean, it's going to take time to do the assessment, to respond, to do a referral, to get them to the care they need. This is the equivalent situation in psychiatry or a mental health in general practice, really, where you're really dealing with a very acute situation and just need to accept that you just cannot do that in 15 minutes. Certainly, as more and more practices have a HIP colleague there, then they can be very helpful, though, in picking up this. The thing I really want to stress, though, particularly about risk, is that that having a HIP and a health coach and access to NGO support really does shift the role of GP also to being the consultant to a multidisciplinary team. And certainly when it comes to the managing of risk, HIP can assess, HIP can come up with recommendations, but actually it really needs to go back to the GP to really take ownership of that, to make the referrals. So even if the HIP helps with the referral, that it goes in the GP's name. So that is certainly one of the provisos about this model, because while all of our HIPs have mental health training, not all of them have acute mental health experience, and many of them indeed don't have secondary mental health experience. So it's really important that you as GPs, as the consultant to the team, are maintaining the overview of that.
I had an interesting experience the other day, Dave, and it's happened to me a couple of times as somebody I thought was seriously ill, and this lady was probably overdosed on methamphetamine. And when I phoned the mental health team, they knew the history and the pattern of this person. So sometimes that referral process, you actually get collateral information which de-escalates the situation. So this lady was eventually sent home to sleep it off, rather than us throwing her into a police car and dragging her off to a hospital, But we didn't know at the time.
Certainly, if you're worried, ringing the crisis team can be really helpful. I mean, I know the equivalent situation is in someone who presents to a general practice, not well known to the practice team, presenting as suicidal, but they are known to the clinic, to the specialist services, being someone who's got persistent suicidal thinking. And I'm going to talk about that a bit later, the ways that sometimes responding in that situation as if the person's acutely at risk inadvertently reinforces a pattern of unhelpful behavior. But yeah, so I mean, bringing crisis teams can be really helpful in that regard. The big challenge being get a hold of someone sometimes, because if they're busy and out on the road, sometimes it's difficult to get a response in the moment.
Can you recommend an online de-escalation training to offer staff?
Oh, that's a tough one. I'm not sure that any of it. So there are a number of organizations that offer it, like Grow, and I don't know if they've videotaped and have available online. But a lot of the really good de-escalation training needs to actually be in person, because it's about role playing. So what's most helpful is just getting some simple skills, but then role playing them to practice them, just to give you the confidence. Whereas doing it online, it will be really hard to actually integrate that element of it into the process.
Okay, so we've got more questions. Some NGOs use some of these techniques, but maybe this is more in depth. Will it be available for NGO staff as well?
If you mean this a process to risk assessment and so on, the problem with NGO staff is that most of them are not credentialed clinicians. And so while they might hear about risk, expecting them to be able to assess it and to make decisions about appropriate response, I think is not a safe thing to be doing. Many NGOs do have nursing staff, so they're available to undertake this kind of assessment. And certainly, increasingly, I expect there will be, as part of increased availability of training in this whole approach, access for all clinicians working across the mental health space. And in the primary care space, what's really been key is that it's not only a HIP being trained, but a GP having a degree of training in the same space. So you're both working to the same process.
Question there from someone who's a HIP. They were told it wasn't a crisis intervention role. This seems to have changed. Has that been evolution in the model, or is that more a contextual situation thing?
Yeah, look, I think it's not a crisis. It absolutely is not a crisis intervention role. And so crisis that can't be de-escalated, be it risk with a robust safety plan at the end of it, or distress, then that is about transition over to a crisis team. I guess what I'm talking about, though, is the role of a HIP to be helpful in the clinic. And sometimes the way of being helpful is to support the GP and really being able to spend some more time fully understanding risk, and then being able to go back to give a view about what needs to be done, including, if necessary, crisis team referral.
Question here from any work going on about having HIP in practices in Central and North Auckland?
So the rollout regionally is including both Central and North Auckland. The prioritisation process is really very much around the Māori Pacific and youth populations. So as time goes on, though, we'll be moving more and more to practices that have less of those populations. Unfortunately, despite the government intent that there'd be funding to roll this program out to all of general practice that wanted it, we and most of the country are not going to get to full population coverage unless there's a further budget bid. And because of Auckland's population growth, we estimate we're probably not going to get to 70% quite of population with access. So there will be clinics and higher decile practices that don't particularly also have a big youth population that won't, at least for the foreseeable future, be able to access the funding to implement this program.
Someone wants a definition of a HIP for those who are not in the main centres.
Oh, sorry. Okay. Well, so a HIP is a health improvement practitioner. It's basically, I talk about a HIP as being a mental health clinician behaving like a GP. So it's one-off consultation with an open door to return, brief session, so typically 15 to 20 minutes, so high kind of reach, if you like, in terms of numbers of people seen, and very much a kind of a behavior change focus. And the core kind of model is focused ACT, which Bruce, you're a big champion of, and have been for a long time. And it's really modeled off an American role called a behavioral health consultant. So, and there is a reasonable evidence base for impact at a population level in terms of a number of measures of well-being, and also of reducing rates of people needing to then access secondary services. Tamaki Health, we call them wellness advisors. Other parts of the country, they may have different names. Okay, look, the last chunk is really around the distressed person who presents as angry and threatening, but I'm also going to include in this people who present as chronically suicidal and or self-harming. So the first thing to understand here is that distress almost always underpins angry, threatening behavior. So it's this whole kind of distinction between internalized distress versus externalized distress. As a broad gender generalization, women tend to more internalize distress into anxiety, depression, men to externalize it into angry behavior and substance abuse. But it's really helpful and important to just always remember when confronted by someone who seems angry and threatening, that actually this is about distress. And understanding that also helps a more empathic response. The person themselves is suffering. I mean, angry, threatening behavior is more likely under a number of circumstances. Firstly, and most importantly, if there's a history of trauma, especially childhood trauma and adversity. So people, and I'm going to go on and talk a little bit about the whole trauma-informed care area, but also if there is any neurodevelopmental condition, neurodiversity, so, diagnoses or symptoms of things like autism spectrum and ADHD. Thirdly, that if there is a personality disorder, and that may be related to one or both of the above two factors. When I'm teaching about personality disorder, I mean, I always ask people, how do you know if someone really has difficulties that you could frame in personality disorder terms? And obviously, we don't have an audience that can easily respond here. But I mean, the way I then talk about it is that these are the patients who everyone finds difficult. And the thing is just understanding more about why they are being difficult. And then occasionally, though, there is depression with irritable mood, but what you'll see then is that this is not the person's usual presentation, or equally hypomania, mania with irritability or psychosis. And in that instance, angry behavior is only present when the person has symptoms of the disorder. The general messages are still first try to de-escalate. Your best aid is a calm, empathic manner. Use of quiet space, time to calm down, reduce sensory overload. If you have it, sensory modulation equipment, as that question before referred to. Maintaining capacity to observe and contain. So hand off to HIP if you have one, or a nurse to just be around and make sure that things are contained. Trauma-informed care. This is based on the understanding that trauma is the fundamental issue for many people with mental health and addiction issues. So the research about that is clear. Early trauma, in contrast to the kind of traditional wisdom, which was that genetics was the biggest contributor, there's been a real shift to recognizing that at a population level, early life trauma and abuse substantially increases, and in fact is the single biggest risk factor for development of all major mental health and addiction conditions, excluding neurodevelopmental. Obviously in an individual, they can have had a relatively normal upbringing and still develop a mental health or addiction problem. I'm talking at a population risk level. What developmental trauma does, though, is two things. You get overreactivity of the limbic system, which is the fight, flight, freeze response system. So in response to stress, people who present with anger or who have developmental trauma are responding with fight and sometimes flight, but often fight. Unfortunately, you also get in parallel reduced hippocampal and frontal volumes. So you have reduced capacity for emotional learning and for our rational or overriding of emotional response. So you will all know that in a 2-year-old having a tantrum is not an unusual thing. For it to still be there at 5 is less usual. But what we see in people with early life trauma is that capacity for emotion for rational thinking, frontal lobe to override emotional response doesn't develop. So they remain prone to fight response and limited capacity to use logical thinking to override that. So typically they're people who, when they feel threatened, feel out of control, and behavior that appears intentional is not. And I think that's the really first key message here. The second thing, and I mean, this is a tragic but very accurate statement, really. Our brains are sculpted by our early experiences. And I have to say, for better or worse, maltreatment is a chisel that literally shapes a brain to contend with strife, but at the cost of deep enduring wounds. So in managing that kind of behavioral disturbance that is a consequence of early life adversity, what's really key is, firstly, just remembering that fear and distress lie underneath. That, again, I'm going to say this thing of breathing, calming yourself, but also ensuring you can easily exit the space is really critical, keeping yourself safe, acting in ways that calm and reassure, reaching out to the person's rational capacity. You'll be okay. We're here to keep you safe and help. And then the key aspects of trauma-informed care, which is firstly maintaining a really respectful demeanor, which communicates you're important. Secondly, seeking to make a connection, engagement. Partly that comes from that kind of gentle reflection using neutral language. Sharing information, so appealing to that rational capacity that is there at some level, and also maintaining a hopeful attitude. So beyond that then is the second area of neurodevelopmental issues. So people with ADHD tend to struggle with impulsivity, irritable mood, poor frustration tolerance. People on autism spectrum tend to have difficulties with tolerating change or uncertainty, poor stress tolerance, and a tendency to be easily overloaded and or have meltdowns if overstimulated or stressed. And that can then present or manifest as angry and seemingly unreasonable behavior. So just knowing if those things sit behind, or even if they're not diagnosed, if there's a suspicion of them, and understanding that that may be part of the picture, because appropriate treatments for both conditions will improve their tolerance of stress and as a result, behavior. And the same general rules for managing angry behavior apply, but for both, that whole thing of timeout, quiet environment, and actually, again, the whole sensory modulation equipment particularly can be helpful in people with autism spectrum in particular. And then lastly is this whole thing of people with personality issues. And I mean, you will know that this is really about the situation of someone having persistent difficulty dealing with most situations across long periods of their life, going back to adolescence, early adulthood. And it's something that persists over time. So someone could present, you know, apparently angry, irritable, demanding, making you think, oh, do they have a personality disorder? But actually, if that's not how they usually are, that is not something else going on. Secondly, and unfortunately, behavior in personality disorder, behavior is resistant to learning or change. They tend to have extreme thoughts and feelings, so extremity of range, intensity, appropriateness, and also behavior. Causes problems in all areas of life, so function is impacted across all domains. And as I said, present from adolescence, early adulthood. There are three clusters, and the only reason to really highlight this is to focus on the one that is most likely to be involved in people presenting with angry, demanding behavior. So the first cluster is the so-called otic-centric, schizoid, paranoid, schizotypal. Typically, angry behavior will only be seen as an occasional thing in people with paranoid personality. They're much more likely to be the litigious, complaining person than the angry, threatening one. So secondly is the dramatic, emotional, erratic, and this is the group that will at times present with both angry and demanding behavior. So particularly the antisocial, narcissistic, borderline continuum. And then thirdly, the so-called anxious avoidance, so dependent, avoidant, obsessive, compulsive. And anxiety, well, in this group, anxiety can drive demanding behavior, particularly things like health anxiety and so on. It's seldom angry behavior. So as I said, it's that second or cluster B group where you are most likely to see very angry, demanding behavior at times. So in terms of managing angry, threatening behavior, if you're going to think of anything, just remember this notion of 4 C's: being calm, demonstrating caring, but also being really clear as a team, being really consistent. So the whole thing, take a breath, don't react, and never argue, raise your voice back. It's really about unwinding rather than winding up anger and agitation. Acknowledging distress, as I've said before, I can see how things are difficult right now, how can I help? Maintaining good boundaries. So really over time and as a practice team, and often does require a lot of communication as a team, but kind of limiting involvement, being really explicit about your rules, staying observant and trusting your gut feelings. If you're sitting in a room with someone who's angry and you feel unsafe, I think you really need to listen to that. Too often people feel they have to stay and then can end up being harmed themselves. So if you've taken a breath, tried to calm yourself, but your gut feeling is just, I'm not safe in here, then I think it's really important, A, that you've set your office up for easy exit, and B, that you either leave the room yourself or ask the person to leave, to say you're feeling unsafe. And I think it's really important to own it, because owning it is much more likely to get through to the person and hopefully have them agree to leave the room. But if necessary, to have a panic button to get help if you need it. But also over time, do set and if necessary, impose consequences. So, you know, police, if necessary, trespassing patient from the practice. So there are similarities in broad terms to the kind of whole notion of tough love / dealing with children in the space. So, it's that kind of mixture of boundaries within which you provide care, but actually really setting and maintaining those boundaries consistently, which is really critical to healthy child development and equally is critical to managing this situation in a primary care as a team. Recognizing and just recognizing that it's normal that you will feel anxious and at times frustrated. It's not easy, it's normal. But also keeping file records and using alert functions of at-risk patients. So if someone comes in as a one-off angry, hasn't been before, isn't again, I'm not saying you put an alert in your file for everyone like that, but certainly if someone has a pattern of this, it's really important to have alerts and to have a shared team understanding of how you will respond and work with this person. The other side of this coin, which is the more internalized ongoing distress, is around people who persistently present with self-harm and or suicidal thinking. Again, a really challenging situation, which is not uncommon in primary care, most commonly associated with borderline personality disorder or borderline personality traits, past trauma, and also current dysregulation of mood. The same general rules as for managing angry behavior apply, particularly the 4 Cs and maintaining a compassionate, neutral stance. The key thing here, though, is understanding that this behavior is best thought of as an unhelpful, help-seeking behavior. So it becomes a way of the person attempting to get help in a way that is unhelpful. And it is a manifestation generally of unbearable inner distress, emotional reactivity, and emotional pain. So the important thing to understand here, and no one would expect that a primary care team should be able to do this alone. But it's really key to understand that managing chronic risk as if this was acute risk tends to inadvertently reinforce this pattern of, and often escalate this pattern of unhelpful help seeking, so it can have iatrogenic effects. So it's really best managed by adherence to a well-developed behavior management plan that's developed by a secondary mental health service team, shared with other places such as ED, primary care, and so on, and that's focused on reinforcing self-coping strategies, rather than as the case in acute risk, where it is our responsibility to take responsibility for ensuring safety. And ideally, these people need access to a dialectic behavior therapy program. Again, part of DBT is, again, those sensory modulation tools. But dialectic behavior therapy, for those of you not familiar with it, is really learning skills and tolerating distress, regulating emotions, using mindfulness practices, and also skills to manage interpersonal relationships better. So look, this is covering a lot of ground at speed. Hopefully it just gives you some sense of the different elements of managing crisis within a primary care team-based context. So thank you.
Thank you, David.
In terms of the integrated model, there are a group of us in Auckland who actually also did quite an in-depth New Zealand Doctor article a few years ago about the integrated model, including all 3 roles, including for each of them a section on a day in the life of, that gives you a really good kind of insight into all 3 of these roles that are part of the integrated model. So for those of you that have a New Zealand Doctor account, if you actually Google, I think it's under the title of the original name for this model, which was Te Tumu Waiora. But if you Google a New Zealand Doctor integrated primary mental health addiction model or program, you should find it.
It was a good article, I remember that. Got a question here from Christine, which might take you the rest of the night, David, but any advice for teenagers who may be more impulsive? Yeah, look, teen mental health is an increasing concern. And yes, of course, teens are more impulsive by nature of that phase of brain and life development, tend to also be much more emotionally volatile, and therefore can have marked shifts in risk based on very immediate factors.
So I think it is a very unique situation. A colleague of mine, a psychologist who shall remain nameless, when she had a couple of particularly demanding teens on her hands, talked about adolescence as, what did she used to say? I think she said adolescence and other psychotic states. But I think it was her way of just reflecting how sometimes it's difficult dealing with such apparently irrational individuals who are often the size of an adult, but struggle to behave as an adult. So look, I think it is particularly important in terms of managing risk to really recognize that risk can be so volatile in teens. My own experience of being involved a number of times in reviews of deaths of teens has been that if that young person could have been got through that night, they'd still be alive today. So just being much more sensitive to the degree to which impulsivity and volatility of mood are a factor on one side, and on the other side also to really try and get a sense of whether that young person has some developed coping skills or not, because it's where you get that triad of a stressful life event like a relationship breakup, that combination of adolescent impulsivity and volatility, and then also not having some well-developed coping skills, which tends to be connected also to the degree to which they have very supportive, healthy relationships with the adults in their life or not. That's where you get that kind of triad leading to much greater risk of a young person then dying by suicide.
David, a question. I mean, we see bits and pieces of personality disorders in primary care, and I think you describe them as being on a spectrum.
Yeah.
And so Fiona here is asking, are we able to access more of your training on personality disorders? Where could GPs and nurse practitioners and nurses go to get something that would not be?
Well, look, I mean, for nurses, particularly in the Auckland region, I do the low prevalence conditions part of the mental health credentialing program for nurses. So part of that is about understanding and managing the psychotic illnesses in primary care, but the other bit of it is around personality disorders. And you're right, it is a continuum. I defy anyone to read the DSM descriptions of personality disorders and not see a bit of themselves in at least one. I think you've got to be a little bit obsessive compulsive to get through med school, among other things.
Okay, so that's good. Specifically with adolescents, would the Manawa app be okay, or is it just for adults?
No. Actually, it was designed including. Oh, am I speaking in a turn here? No, I'm almost certain it was developed with including teen input, and certainly very appropriate to use in teens, and particularly to look to involve, though, as the third person, an adult, a safe, caring adult in their life. There is another app, actually, while we're talking about teens, that very much focuses on teens building resilient coping skills. It's gone out of my mind, the name of it. I had it there a minute ago. It's a New Zealand developed with co-designed with youth, particularly Māori Pacific youth, and it's a great tool running through 6 evidence-based strategies for self-regulation and coping.
Louise is saying grow.co.nz offered a good workshop on borderline personality disorder last year. I think they do it every year. I've done it with them as a audience. And I mean, the thing with the borderlines, of course, is you never win, do you? That's always the take-home message. You know, you try your hardest and
well, look, in fact, I mean, I think with people with borderline personality disorder, more than anything, the notion of going under is so critical, because if you have borderline personality, you exist in a state of duality. And if we, as health professionals, hold the competence, then it only leaves them with incompetence. If we as health professionals hold the responsibility for risk, then it only leaves them with not taking responsibility for risk. So it's very much about a very carefully negotiated process of really, you know, reinforcing that we cannot keep you safe, an agreed plan, though, around what you've said helps you when you're distressed, and our role being to reinforce you using the things that actually keep you safe. But yeah, you're right. I mean, it is in no way easy work. And, you know, I mean, it is a matter of degrees, but, you know, some practices have a lot of people who are very challenging to work with and manage and within the realities of primary care. And I mean, it's really interesting. It's a bit of a sidetrack, but more and more psychiatrists are getting into primary care liaison roles up and down the country. And so we have a peer review group that they all join. And invariably 3 to 6 months into their roles, they'll say at some point, gee, you know, I had no idea about the complexity of mental health need that GP teams are dealing with every day. I think that's quite a revelation to them.
Yeah, no, that's not the first time I've heard that. That's true. Fitu, is that the app you're after?
Yes, it is. Thank you. Yes, it is.
They look like there's a couple. There's Fitu for schools and Fitu. It
is a downloadable app, so it will be Fitu that is the one that is the downloadable one.
Okay.
So if you go to the App Store and type in Fitu,
yep.
That's the app I'm talking about.
Okay. Cool.
So it takes rangatahi through 6 structured lessons in applying a set of different coping skills. If you Google Fitu, you'll see actually some really easily digestible content, even in Google Images, of the what it takes rangatahi through.
Okay, well, thank you very much, David. That was a start.
My pleasure. Yeah. Okay. Well, look, thanks, Bruce.
Okay,
Lovely
David.
to see you as always, and
yep,
ka
okay.
kite, everyone.
Okay. Bye-bye.